Hi, everyone, and thank you for joining Financialization in Healthcare, How Wall Street Payouts Threaten Our Health. I'm Natalia Renta, Associate Director of Corporate Governance and Power at Americans for Financial Reform Education Fund, and I'll be your moderator today. We are co-hosting this event with the Health and Political Economy Project, or HPEP. HPEP is based at the New Schools Institute on Race, Power, and Political Economy, and its mission is to build a more just and inclusive economy that enables health and dignity. They do this by seeding and socializing ideas that can achieve this mission and building power alongside decision makers, practitioners, organizers, and scholars, just as we are doing here today by connecting the dots between short-term shareholder payouts and their consequences for healthcare. And we're excited to have Victor Roy, HPEP's director, on the panel today. You'll also be hearing from economist and lawyer Lenore Palladino and doctor and health policy expert Donald Berwick. Today's discussion will be about the healthcare we receive, its accessibility, affordability, and quality, and how it's being influenced by corporations' prioritization of short-term shareholder payouts above all else. We all interact with the healthcare system in one way or another, and many of us experience significant financial burdens and concerns or questions about the quality of the care we receive or don't receive for that matter. And unfortunately, many of the players calling the shots, including health insurance and pharmaceutical companies, are corporations that prioritize short-term payouts to their shareholders above access to quality healthcare for all of us. For example, trillions of dollars are extracted from the healthcare system through financial engineering practices like stock buybacks. This is money not put towards discovering new cures, making medicines affordable, or improving access and the quality of the care we receive. We'll be talking about stock buybacks a lot this discussion, so I wanted to give a quick primer on what they are for those who may be unfamiliar. Stock buybacks are when a publicly traded company purchases its own shares in the open market, resulting in fewer outstanding shares, which artificially boosts share price. That's because when there are fewer outstanding shares out there of a particular company, all of a sudden, each individual share represents a larger piece of a company's equity. And corporate executives have many incentives to engage in this practice, one of them being that about 80% of their pay is tied to the equity of the company. Before 1982, companies had to worry about being held liable for market manipulation if they engaged in stock buybacks, so they spent very little on them. But in 1982, the Securities and Exchange Commission changed the rules, creating a very large safe harbor. So if companies stuck within particular parameters on their daily stock buybacks, they didn't have to worry about getting sued by the SEC. And some have referred to this change as in effect legalizing stock market manipulation, and you'll hear more about what that's resulted in. Okay, let's jump into this discussion, after which we'll have time for some audience questions. You can start putting them in the Q&A box during the discussion, and we'll get to them at the end of the webinar. First, I'm going to introduce Victor Roy, who is a physician, sociologist, and author of Capitalizing a Cure: How Finance Controls the Price and Value of Medicines. His research investigates the influence of the financial sector and logics in our healthcare system and its impacts on patients. A practicing family physician, he is assistant professor of family medicine and community health at the University of Pennsylvania and directs the Health and Political Economy Project, a field catalyst initiative aiming to build a just and inclusive economy for health. Victor, can you tell us what you found in your new research on shareholder payouts in healthcare and why it matters?
Thanks so much, Natalia, for setting the scene, and it's really great to be in conversation with you and Lenore and Don on this topic. So you already helped set some of the context, but I'll before I dive into specifics of some new research and what it means, I think what motivated this research is just really the growing concern that a larger proportion of our healthcare dollars are growing to economic actors in the financial sector, seeking short-term profits rather than the things that we would want, like you mentioned, enhancing affordable access, investing in research and development, or improving quality. And it's not an abstract concern, right? It's something that's tied to what I see in clinic as a family doctor, people who are denied care or are worried about copays for a medication they can barely afford. And it also actually impacts the people I don't see in clinic, right? The people that might not seek care when they need it because of the bill they're worried about getting. And this is happening at a time, and we're going to get much more into this when, government does finance a large portion of our healthcare, and people pay a larger share of their wages on healthcare through insurance premiums and out-of-pocket costs. So what I looked at and what my research team together with colleagues at Yale looked at was, how much capital are the largest healthcare companies in the US distributing to shareholders, right? We wanted to follow where some of our healthcare dollars are going. And this isn't our entire healthcare system, but it's an important slice of it. And others have looked at, profits, but actually this goes a step further in actually looking at where do profits go. And so what we did is we looked at the S&P 500 healthcare companies from 2001 to 2022. And we've identified 92 companies that were traded on the S&P 500 that are healthcare companies. Um, and we tracked their financial data. So what did we find? So we found that those 92 healthcare companies distributed $2.6 trillion to shareholders during that time period, or 95% of their net income, which is a measure of profit. So I want to just highlight three things about this kind of top line finding. One is that it's a figure on the rise. So in 2001, this was $54 billion. And by 2022, we see that, healthcare companies on the S&P 500 distributed $170 billion. So it tripled over that time period. Buybacks is another thing I wanted to highlight. You mentioned this. So of those $2.6 trillion, those that distribution to shareholders came in the form of dividends and buybacks, but 60% of that came in the form of share buybacks, which is, as you mentioned, was not a common practice until recent decades. And this activity was really concentrated. So 19 companies, or 20% of the sample, were responsible for 80% of these payouts. And so pharma, biotech, managed care conglomerates were some of the biggest players. And I'll just highlight a few examples. They're not in the paper itself. And I should mention, yeah, it's in the chat. The Pfizer directed $363 billion. United Healthcare, which has been in the news, right, $128 billion. And one of our for-profit hospital systems that is traded, publicly traded company, the Hospital Corporations of America, distributed $89 billion to shareholders. So I just threw a lot of big numbers, right? And we're going to unpack, I think, how this has come to be, what it means, what the implications are. I'll just kind of briefly mention here, because we'll have much more discussion about this, how to view these numbers in a sense is that they're kind of a symptom of an underlying set of dynamics in our economy, more broadly speaking, as well as our healthcare system and their convergence, right? And that convergence is leading to a large share of value extraction, we can call it. Short-term focus on that value extraction and through concentrated economic power. And this has downstream harms for patients, for workers, for innovation. And that's, why we're here to talk about this, I think.
Thank you so much, Victor. And now I want to bring in Lenore Palladino into the conversation, who is an associate professor in the Department of Economics and School of Public Policy at the University of Massachusetts Amherst. She's a research associate at the UMass Amherst Political Economy Research Institute and a senior fellow at the Roosevelt Institute. And she is the author of a book on the political economy of corporations, fresh off the presses, titled Good Company, Economic Policy After Shareholder Primacy, and it was published by the University of Chicago Press. So Lenore, you've done extensive work on what Victor is describing in the broader economy. Can you tell us about how this kind of strategy has become dominant and its harms for our economy and healthcare?
Yes, and thanks so much for organizing this webinar, Talia and AFR and Victor, and thanks for everyone who's taking some time out of a busy day to attend. Unfortunately, what Victor is talking about in healthcare, the same dynamics are prevalent throughout the entire economy. And, my work is really about reframing how we understand corporations so that we can make policies so that as our leading social institutions, they do what they're supposed to do, which is produce and innovate, not simply extract value for an economic elite. So just a couple things to try to describe this idea of shareholder primacy that really shapes the exact dynamics that Victor's talking about in healthcare, where the vast majority of profits earned go to shareholders rather than be paid in higher wages or go into the reinvestment of the business. So private corporations never stand outside the public realm. We always have government shaping markets. And a corporation in particular can't exist as a business with its privileges of limited liability and perpetual existence without a stamp from a Secretary of State. So it's explicitly got that grant of permission from the public to operate, which means, in my view, that we have the right as the public to set the rules that shape how businesses engage, how corporations engage our economy. So what's shareholder primacy? It's really a framework or a paradigm for corporate decision making that says that shareholders are the only corporate decision makers, and they're the group that really should benefit from the profits from corporate activity. It is true that in the US, state law has defined the purpose of the corporation as distributing profits to shareholders, but that doesn't mean we should, stop there. We need to actually remake this paradigm and rewrite the rules that govern corporate behavior. This idea of shareholder primacy is really based on this false concept that shareholders are the only ones who take a risk in the corporation. They should vote because they are the only actor that actually has something at stake. It's a theory of allocating corporate profits to shareholders, but not a theory of how to actually shape corporate decision making so that corporations innovate and produce. Workers, management, even the main people who participate in a daily way in the activity of the corporation aren't the ones making corporate decisions. It also ignores the fact that corporate productivity and innovation comes from the interaction of management and the workforce, corporate leadership, and investments from the state, as well as in many cases from customers. And this framework really takes away from any attention on how the innovation process really works. So far from being this anodyne academic theory, the shareholder primacy framework really shapes how, as Victor said, in healthcare and really, unfortunately, all sectors of our economy, trillions of dollars are flowing from corporations to financial institutions, asset managers, and others, and eventually to the small group of mostly white, wealthy households who own the vast majority of corporate equity. And this is really important because we have this myth in our country and in our political, imagination that everyone's a shareholder, that the majority of us own shares, and that when companies make shareholder payments, that benefits mom and pop retirees. But that's simply not how actual shareholding is structured. The vast majority of stock is owned by a very, very small percentage of our population. So I think that understanding this framework of shareholder primacy helps us understand why stock buybacks in particular are so problematic, but more broadly helps us understand why we've moved away as a society from a focus on improving innovation, which is important across all sectors of the economy. But in healthcare, I mean, we can't even, none of us can imagine a healthcare sector that hasn't innovated over the last, hundreds of years. And I think our healthcare system is one of the places where we should care most about making sure that companies are able to be innovative.
Thank you so much, Lenore. And now I want to bring in Dr. Donald Berwick, who is President Emeritus and Senior Fellow at the Institute for Healthcare Improvement and former Administrator of the Centers for Medicare and Medicaid Services. A pediatrician by background, Dr. Berwick has served on the faculty of the Harvard Medical School and Harvard School of Public Health, and on the staffs of Boston's Children's Hospital Medical Center, Massachusetts General Hospital, and the Brigham and Women's Hospital. He has also served as vice chair of the U.S. Preventive Services Task Force, the first independent member of the American Hospital Association Board of Trustees, and chair of the National Advisory Council of the Agency for Healthcare Research and Quality. He served 2 terms on the Institute of Medicine's Governing Council and was a member of its Global Health Board, and served on President Clinton's Advisory Commission and Consumer Protection and Quality in the healthcare industry. Dr. Berwick is the author or co-author of over 160 scientific articles and 6 books. He currently serves as lecturer in the Department of Healthcare Policy at Harvard Medical School. So Don, you've been a leader in healthcare, you've run Medicare and Medicaid, you've also run for public office. What have you seen from your front row view of policy in healthcare about how putting short-term profits first is impacting our health system?
Thanks so much, Natalia, and thanks to AFR for inviting me to join this conversation. And nice to work with you, Victor and Lenore. I think that the stock buyback topic that's a focus here and of Victor's recent research is one corner of a vast set of changes that Lenore is talking about, which is the overall financialization of healthcare. Money is running healthcare now. Far more, I think, than most of the public understands. I don't know if there was a good old days when money had nothing to do with healthcare, but there was a good old days when there was more focus, I think, on meeting the needs of communities and patients as central to everyone's activity. And that if you wanted to make money, that was the way to make money. That's not what's happening now. Sector by sector, we're seeing accretive and I must even say greedy activities that are well executed by companies that know exactly what they're doing. For the public, probably the most evident or famous part of this is pharmaceutical pricing, where we now have drug development that's putting with prices that are just putting drugs out of the reach of many, many people who need them, and also breaking the bank for the both public and private treasuries. And it is extremely confusing. I think we ought to have a Saturday Night Live skit on what it's like to go to the pharmacy counter and try to get your drug and guess how much it's going to cost you. We see it, unfortunately, in hospital behaviors. The hospitals are essential. They do great work, but they're also consolidating more and more in markets and using that market consolidation to control and raise their own prices instead of working as hard as I believe they should be on reducing total healthcare costs. The insurance system is captive now of financial interests. The part of it I've studied the most is Medicare Advantage. That is the privatization of Medicare and the profits being made in that sector now with insane subsidies, overpayments to Medicare Advantage plans are now more and more in the public eye, thanks to good journalism. MedPAC says that we are probably overpaying Medicare Advantage plans by about over $80 billion a year. I think it's closer to 100 billion. That's a lot of money. And it's done through gaming rules and coding and systems. We can get into more detail if people would understand more about it. And then private equity, private ownership of healthcare now, where the owners, they have no real deep interest in the quality of what's going on and the help of the patients. They want to get short-term high profits. And they flip organizations. We saw the disaster with Steward Health, but that's not the only example. There's very good evidence, very good research on all of these effects on health status. We know now, for example, that private ownership of hospitals, autism programs, nursing homes are associated with higher costs and lower quality and increased death rates in the case of nursing homes. We have, by the way, I noticed on the line, Hayden Brookley, who's a researcher in this field, now affiliated with Brown, who's done tremendously good writing on the effects of consolidation, and they're not positive. So the stock buyback plan, which Victor and Lenore have explained, is a part of this overall increasing focus of milking money from medicine. The effects, they're bad. Patients feel more and more out-of-pocket costs, uncertainty about their access. Companies increase their short-term profits by finding ways to deny access and creating all sorts of complexity that make it hard to understand what's going on. And debt is enormous. We have over 110 million people in this country in medical debt. It's I think now the largest cause of bankruptcy in the country. No other nation on earth can make anything like that. That sad claim, and clinicians don't like it. The clinician burnout we're feeling, the moral injury we speak of, comes from when clinicians get trapped in the gerbil cage of having to see more and more patients, do more and more revenue-oriented tasks, code higher and higher, which isn't why they went into medicine. So we've got a bad trajectory. Thanks to Citizens United and the forces of lobbying on Capitol Hill, it's really hard to fight this. And what you're doing with AFR, trying to alert the public to this and create public momentum to push back, is absolutely essential. There's no other way we're going to turn this around.
Thank you so much for that, Don. It's very distressing. And I want to bring back Victor, who's done work describing, of course, the financialization of our healthcare system. So can you tell us about what this research teaches us about financialization?
Yeah, I'll take, Don gave a really great tour of, financialization and how it's shaping different parts of our healthcare system. The part like Don shared, this is looking at just a small slice of some of the larger trends that he was pointing to. I will just take a moment, I think, for folks that might not be familiar with this term financialization, what does that mean? I think more folks will be maybe familiar with the term or the idea of privatization. So, something like Medicare dollars increasingly going into private hands, right? It's like kind of referring to the ownership and control status of a public asset, turning it more into a private asset. Financialization builds on this idea, but it kind of takes it a step further by describing how, in this case, corporate actors become oriented around financial actors and financial maneuvers like buybacks or acquisitions rather than investments in productive activities related to healthcare, and kind of how finance gets uncoupled from what we actually need for healthcare. And one, so the study that I described earlier, it provides a set of empirical data points for this slice that the paper looked at of large publicly traded healthcare companies. And we thought it was important to have this kind of empirical evidence as part of the policy debates, as we're trying to understand how to respond to some of these forces. I think it's also helpful, Don mentioned, insurance companies that are really not just insurance companies now. There are many other things that we can talk about, conglomerates, pharmaceutical companies. I'll just also give an example of another kind of company that was part of the sample, just to make these kinds of some of the dynamics here vivid. So I'll describe the example of DaVita. It's a dialysis company, right? It's got 40% of the market here in the US. There's at least 600,000 people in this country that have end-stage renal disease, impacts Black Americans disproportionately. And DaVita is a company that generates 70% of their revenues from Medicare and Medicaid. And so patients go to dialysis facilities to get dialysis. The government reimburses for much of this. And in the sample, in the last 10 years, DaVita as a company distributed over $10 billion in buybacks, actually more than they made in terms of profits, in part by acquiring more dialysis facilities, taking advantage of public reimbursement, and then distributing gains in the form of share buybacks. And we know that dialysis tech workers are often low paid. We certainly could use more innovation when it comes to dialysis technology, and there's racial and geographic inequalities when it comes to dialysis that would require more investment. And we could be mobilizing public investment to try and solve these challenges, but at least some substantial share is actually subsidizing shareholder payouts. And so that's one of the ways in which financialization works. And part of the argument here is that we need to recouple finance to real investments in healthcare that are affordable, accessible, and high quality. And understanding this bit on financialization at least gets us to understand why it's not happening, and I know we're going to be talking more about what to do about this.
Thanks, Victor. That specific story about the dialysis company is very illustrative. So Lenore, what are some of the stories or myths that sustain this approach to corporate governance despite the clear harms that we've been discussing here?
Yeah, I think I'll talk about two myths that I think really matter when we think about financialization and shareholder primacy. The first is this myth that I spoke about before, that we're all shareholders, and so everybody benefits from shareholder payments. And the second, this myth that shareholding and investing are synonyms, that they mean the same thing, that share trading equals real investment in corporate innovation and production. So I spoke about the first myth a bit before, but let me just crystallize it very quickly. Let me tell you who holds corporate equity and mutual fund shares according to the Federal Reserve. And you will think I'm making these numbers up because they are so symmetrical. But the top 1% of households in the United States in terms of wealth holds 50% of all corporate equity and mutual funds. And the bottom 50% of households by wealth holds 1% of all corporate equity and mutual funds. And really, you can go and look for yourself. These are the numbers as of the third quarter of 2024. The flip is really important to understand in terms of where the benefits of shareholder payments that go. The practices also deepen the racial wealth gap in the United States. White households hold 88.6% of all corporate equity and mutual funds, while African American and Latino families respectively hold less than 1% each, 0.7 and 0.6%. So when we talk about shareholder payments, we really need to understand who shareholders really are, where the money is flowing, and how it's perpetuating economic and the racial wealth gap. And then the second myth is something that I've been thinking a lot about lately and writing about. It's the idea that the myth that shareholders are investors, or the myth that all share trading activity creates positive investment inside corporations. So we have this idea that when shareholders gain corporate profits, they recycle that money into new investments, right? When we really think of investment as the term referring specifically to improving the productive capacity of a business. I think this myth persists because it's very beneficial for the economic elite. Institutional shareholders and asset managers hold tremendous power in our economy, and they frame their importance as being that they are the ones that provide the necessary financial assets to support the entire economy, to create jobs. Great quotes from private equity leaders saying that they are supporting the teachers and they are the job creators. This myth is simply incorrect, but it's so deeply rooted that it's sometimes hard to see. In publicly traded markets, shareholders largely trade shares on the secondary markets, which mean that if I purchase a share from Victor of Coca-Cola or whoever, Pfizer, let's say in this case, that the money that I pay to Victor to purchase that share goes to him. It doesn't go back to the company. It's only when companies first issue stock that they gain money directly from share trading activity. On the private market, so where the transactions that are happening are not disclosed for reasons we could talk about, we don't have publicly available data, but we know that how private equity has been behaving, as Don spoke about. We know that private asset managers, their business model is to extract value over a short period of time rather than do real investment in companies for the long term. So in summary, I think, breaking open our ways of thinking about who shareholders are, and also the fact that share trading is not the same thing as real investment, will really help us understand why these activities are so harmful across the entire economy.
Thank you so much for that, Lenore. Dawn, you've also written about corporate greed in healthcare, and wanted to ask, what are some of the stories or myths you see in healthcare policy that enable the profiteering that we see? Myths all over the place in this discussion.
Yeah, absolutely. I loved Lenore's comments. Let's go back to the managed care, the Medicare Advantage world. So we have this dynamic that goes on. It's allowed by law. We need public sentiment to change it to allow upcoding of patients, where Medicare Advantage plans get paid more when there are more diagnoses in a patient's chart. Um, and they claim that that's better care because now we're recording everything that should be treated about the patient. What they don't tell us is that the vast majority of those diagnoses have nothing to do with treating the patient. And in fact, when you see if the patients were treated for them, they're generally not, because they shouldn't be. They're just extra information about the patient that is not of clinical value. For some reason, United Health Group published last year or the year before patterns of coding between traditional Medicare and United. I think it was United patients. They said Medicare Advantage patients for a diagnosis of peripheral vascular disease. That's narrowing of the arteries. United has been sending nurses and others into patients' homes to do very detailed studies to see if arteries are narrowed. They are, of course. They're older people. It doesn't need treatment. In the traditional Medicare population, 10% of patients carry that diagnosis of peripheral vascular disease, and many of them probably do need some care. In the United population, it was 50%, 5 times as many had the diagnosis, which had nothing to do with the care, but did get them paid something around $2,500 a year more per patient. So when you look at the details of how some of this access to overpayment occurs, you find story after story like that.
Wow, thanks for sharing that, Don. And Victor, you mentioned at the end of your paper that policymakers could take lessons from other sectors. So can you tell us more about that?
Yeah, I think it's good to try and talk a little bit about, even in this political climate, at least some of the ideas we should be thinking about. And of course, a short conversation won't cover all of it. At the end of the paper, so it was a very brief research letter, and so I encourage people to read it because it's 600 words. But we make reference to the semiconductor industry, and Lenore, you might actually have more to say on kind of this idea of conditionalities. But the attempt here was to, at least first of all, with this entire conversation, is to put these issues more squarely in the health policy kind of map, looking at where profits are flowing and what the implications are of that are. But in terms of making reference to the semiconductor industry and other sectors, is this idea of conditionality, particularly with the fact that so much of our healthcare dollars do come from the government, from taxpayers, from the public. So there was the example with the Chips and Science Act, where the Biden administration's Commerce Department was looking to set conditions on public funding for companies that were going to receive public funding to forego share buybacks and to actually invest more dollars in things like childcare that really affect the labor, workforce and the workforce. And so those kinds of ideas, I think, are largely kind of absent from the kind of health landscape. They would look different, I think, but you can take the example of Moderna, right? As a pharmaceutical company, they received significant amounts of public investment to take the COVID-19 vaccines to, the broader public. They also, government paid for, purchasing these vaccines for people. And Moderna's in our sample, right, as a company that engaged in high levels of share buybacks after they made a lot of money on COVID-19 vaccines. What would it have looked like for the government to set stronger conditions on access and pricing? And what could we have done in terms of the public health response with that? So that's one set of ideas. I think that there are other ideas, that are part of our economic policy discussions around antitrust. We've seen more momentum around, this movement around anti-monopoly, and some momentum around applying this to healthcare. And so I think that there's more that we could explore there, maybe as part of the Q&A, or if others want to chime in on that. And then I think, Lenore's book has a whole menu of ideas for actually thinking about the broader landscape, right, of of corporate governance, I think different kinds of ownership. And in healthcare, clearly there's a need for that. And even thinking about public ownership and public options as part of our economic policy toolkit, given the fact that healthcare is an essential human need, and we could be doing much better on how we actually mobilize that investment that we already make.
Thank you so much, Victor. And that's an excellent segue to ask Lenore about her excellent new book, where she lays out a series of ideas for what we should be doing on corporate governance. And so would love if you shared what would be most relevant to our discussion.
Yeah, thanks. So, the purpose of my book, it's called Good Company, Economic Policy After Shareholder Primacy. It's definitely optimistic, maybe these days. But the purpose is to put forward a set of policy reforms that would really rewrite the rules of how corporations operate to push more in the direction of innovation and productivity rather than being extractive as they are today. And I'll just say, right now in the United States, it feels difficult for me to focus on this kind of structural reform, this kind of policy making. But I just keep in mind that I think corporate and elite power is what got us here. And so we need to continue our work at all levels of government, at all levels of policy to really rebalance power. Um, so the book lays out a set of different policy areas, and I'll start with the set of policies that could limit financial extraction. And there's lots we need to do to regulate finance and corporate financial practices in the public interest. This has been AFR's work for over 15 years now, but I'll just talk briefly about stock buybacks again. So just to reiterate, stock buybacks are when corporations that have publicly traded stock go to the open stock markets and repurchase their own stock for the express purpose of raising share prices because there's less stock left out there, but the market value of the company stays the same. So each piece of the pie is a little bit bigger. The reality is that corporations with publicly traded equity face enormous pressure to maximize shareholder value from financial institutions that are asset managers of pooled funds, as well as the activist investors that we hear about in the financial press all the time. They use stock buybacks to satisfy these demands they're getting from certain groups of shareholders who are looking for quick returns. And their purpose is really to legally manipulate stock prices, while at the same time, perhaps non-coincidentally, they benefit corporate executives whose compensation packages themselves have become more and more based on stock prices over the last several decades. So I talked before about the broader effects of shareholder primacy, but I have a number of specific policy reforms that go from banning stock buybacks altogether because they are, after all, market manipulation, which we don't like in our economy. It's very strange that we allow these in the first place. But also some more common sense, bright line rules that would actually keep us very much in line with the rest of countries with advanced financial markets, rules that essentially put limits on stock buybacks. Right now, there are basically no limits on what companies can do. And even the mildest regulatory reform that the SEC did put forth under the Biden administration, the Chamber of Commerce went after it, and it was struck down by the courts. So we do have a very big hill to climb in front of us. I also think some of what I try to do in the book is lay out some more positive types of reforms that could really support innovation and productivity. First, I think corporations, we should have a federal charter, as was contained in Senator Elizabeth Warren's Accountable Capitalism Act. Very briefly, most large corporations are chartered in the state of Delaware. For historical reasons, we live in 2025 in a globalized world. We should have federal corporate law. We should have multi-groups of stakeholders on corporate boards. Shareholders aren't the only key stakeholder in the success of a corporation. There's the management, there's the workers, there's the community and the public, there's customers. We can structure corporate boards and corporate ownership in different sectors in different ways. We don't need to only operate according to shareholder primacy. And then I also have sets of proposals that look at, well, what would it look like if employees also were holding corporate equity in ways that made them beneficiaries at the same time that shareholders are benefiting. So there's a range of options that I think we have. I think the most important, point for me is that these are all pragmatic reforms that exist in other countries. We're not talking about wild new ideas, but because shareholder primacy is so deeply entrenched in the US economy, we get results like what Victor's letter tells us, that healthcare companies, 70% of their funding, I think I saw in your letter, comes from the public one way or another. And yet they're paying out 90%, 95% of their profits in shareholder payments. That just doesn't make any sense. And so we have a lot of options to really reform the structures of corporate decision making back towards innovation and productivity. But what we really need is the political will.
Thank you for that, Lenore. And I'm going to use moderator's privilege here to say a little bit more on that topic and actually answer one of the questions we got about the tax code and how it could be used to address the drivers of financialization. And I think, the tax question is particularly salient right now because, as folks probably are aware, there was a huge tax giveaway to large corporations in 2017, and we are looking at another big tax fight when some of those expire. And one of the big narratives in 2017 when when corporations were pushing for these tax breaks was, we'll use that extra money to raise worker pay, to increase quality of our products, all these things, and instead they went on a stock buyback spree with the S&P 500 firms alone spending $806 billion on buybacks in the first year after that tax reform, which was a massive jump from the $519 billion they had spent the year before. And, as we've discussed, that has not abated. And there are some analysts that are predicting over $1 trillion in spending this year in stock buybacks. So I think let's not fall for that. Yet another myth in this discussion, that corporate tax breaks somehow trickle down, right? And in the Inflation Reduction Act, actually in 2022, there was the first ever excise tax on stock buybacks at 1%. And there have been bills introduced to increase that to 4%, and other calls, to just, disincentivize this practice. And, like Lenore said, at Americans for Financial Reform Education Fund, we've done a lot of advocacy at the Securities and Exchange Commission, which basically created this problem in 1982. So there's a lot to do there. To actually have common sense guardrails on this. And what Victor was saying earlier too about, public money should come with strings, right? We don't want to be subsidizing huge payouts, short-term payouts. So just wanted to bring those few things for us to the conversation, but I wanted to also just kick it back to Dawn to see what are some of the directions you would urge, even in this political climate.
Well, the last in this political climate is quite a qualifier. I personally have lost faith with private ownership of the delivery of care by organizations that are primarily financial organizations. To be clear, I no longer believe that it's a good idea for private equity to own hospitals or physician practices or autism care. They've lost the trust that they could have had. So I feel that the acts of caregiving, the delivery of care to patients, should not be purchasable by financially driven organizations. Bottom line. There is a problem that Lenora notes far more about than I do, which is how to raise capital, because nonprofit organizations and others still have to have capital, and where you get that capital can be from private investors, of course, but not through the ownership of the delivery of care. That would be one line I draw.
Thank you so much, Dawn. And we are appreciative that you actually answered a couple of questions from the Q&A. here in writing, but wondering if you wanted to say a few words about those responses. One of them was about Medicare Advantage and its role specifically in rural areas. So wonder if you could speak a little bit about that.
Yeah, I couldn't put it in the chat, but I put it in the answered questions. So the questioner is asking about Medicare Advantage and how it rose, and especially its effect on rural areas. It just so happens that my colleague Rick Lafillin and I just published a couple of days ago a long paper, a short paper that has a long you can get access to the longer version in the American Journal of Managed Care, and I urge people who are interested to read that. The question is why, after really nearly 50 years of investment in managed care and what people call that various forms of value-based care, do we not have a result? And we don't. And this paper tries to describe the history of the migration toward managed care and why some of it has failed. A lot of it has to do with with the lead role of financialization in healthcare. I have to say, as a pediatrician, I only ever practiced in an HMO, a managed care environment. It was wonderful. It was not for profit. I was never coached to try to upcode or anything. I had resources and colleagues who would help take care of patients. The other question that I answered had to do with regulatory steps that state governments can take. So there are a number of states in the country. An incomplete list is Connecticut, Massachusetts, Maryland, and Rhode Island. I think more recently California. They have public commissions now with various kinds of charge to track and report patterns of healthcare costs, and with various levels of authority. I think it's the beginning of something. I think the more transparency we have on who owns care, what's happening to prices, what's happening to total care, and who's paying the bills, the more likely it is that we'll get public sector policies that try to rein in some of these bad behaviors. So if you're in one of the states that has a health policy commission, find out about it and attend their meetings.
Thank you for those recommendations, Don. We have a few other questions. One of them says that financialization has led to an extreme but broadly adopted myth that the role of government is to channel public resources to financial actors to enable their pursuit of private gains. And how can we challenge this and provide counter narratives like that financial actors must pursue private gains responsibly while fairly contributing to public resources and benefits rather than just extracting or decimating them? Does anyone want to weigh in here?
I mean, I can say, that's a huge question. I think we're trying to answer it in some ways in the whole panel. But I think I want to just mention a little more something that's been going on in Massachusetts, in Don and my home state, which was a private equity takeover of a hospital chain. The owner, Steward Healthcare, really, really decimated the quality of care that people were receiving inside the hospitals. And I'm not a doctor or a healthcare practitioner at all, but I got to actually sit and hear from many of the nurses at a public forum where they were telling excruciatingly painful stories about the changes that were made, the drop really just overnight as ownership changed of their hospitals, and the pain they felt at the changes they had to make in terms of how they provided quality of care. And I think it's so important that we hear these direct stories of the impact of financialization on people's lives. I think it's true that we can see these practices happening across the economy, but when they're happening in healthcare, education, childcare is being financialized, home healthcare is being financialized. When we see the direct effect it has on all families and people's lives, it really can provide that public will to call on our policymakers to take action. And as Don was mentioning, private equity in particular in healthcare, there's been state legislation proposed in California, Massachusetts. There's sort of back and forth in terms of how the legislation has moved forward in both states. But I think we need to both keep these real stories in mind of the pain and the impact that people experience. Plenty of other industries, when companies are financialized, mass layoffs occur, whole communities are decimated. So it's across the board, but in healthcare, we have some of the most excruciating examples. And we need to call on our policymakers to take action to really limit the ability of financial actors to extract value from the rest of us.
Natalia, can I jump on that with another comment? So first, the question about rural hospitals and this trend. Ed Weisbart posted a very good paper on rural hospitals. Just remember, when the drivers are financial and the time horizons are short for short-term returns, and where there's no real focus on the quality of the patient care, then the attractive investments are not going to be in the low-income, rural, or small markets. They're going to be organizations that either are wealthy or have a lot of real estate that can be flipped over into value. So there's an inherent bias, I think, imbalance here, that investment-oriented financialization is going to harm rural and underserved areas more than others. I think the other thing is governance. I want to go back to some research that's been done on actually who's calling the shots in the healthcare delivery systems. And we have a problem there, which is the boards of trustees of hospitals and especially large healthcare systems do not contain people who have much experience in patient care. They're the same people. They're investors, hedge fund managers, real estate people, good people, very successful business people, care about their communities, but they don't understand care. And another change that I think needs to be made to rebalance here is to have those who govern delivery systems represent much more thoroughly clinicians and patients, not just financiers.
I'll also just jump in here. I co-sign everything that Lenore and Don just shared. I think that anytime we're talking about, building counter narratives, part of it is, obviously as a doctor, I really believe in actually telling the frontline stories of what people are experiencing. I think in many places, financialization, and in other parts of the economy, it can be an abstraction. And, the things that Lenore was discussing is far from, it's the opposite. It's very concrete and often very immediate impacts that people have had. I think on the policy level, this paradigm in that question that, you shared is kind of this idea of the public-private partnership, right? And that's kind of the model that we will ostensibly talk about in healthcare as, that's what we have. The public is financing, the private sector is going to drive efficiency. And the word efficiency, of course, is very much part of our time right now, and we're seeing it being used for lots of different ends. I think as part of that policy conversation, in healthcare, we talk a lot about value, but I don't think we talk enough about, who's creating that value, and oftentimes which are the actors that are extracting, and where value goes. And so value is a much more dynamic concept. And I think part of the stories that we need to tell are, the places in which workers are creating a lot of value. Public investment is creating a lot of value. And people are taking enormous risks at in different parts of whether it's public investment in ensuring our kind of our elderly people in America, or low-income Americans, and where the rewards are flowing, right? So I think some of the words that we even use to talk about health policy, whether it's value, whether it's risk, there are different ways that we could actually be talking about it, in addition to what Lenore shared earlier about investment, that I think all kind of start hopefully creating a different lexicon around this narrative that can underpin whatever policies we're actually talking about, or changes we're talking about.
Thank you all for those great responses. One very timely question we have here is that even prior to this administration and the decimation of an alphabet soup of regulatory agencies, I'm not going to mention all of them, regulatory capture and elite capture were prevalent. Is it possible to conceive of responsible capitalism without addressing the underlying political economy that allows the wealthy to capture democratic institutions?
Yes, we have to. We have to conceive of better systems. We, I think, are in a moment where we're seeing the fruits of 40 years of neoliberalism and we're experiencing the decimation of the federal government. I think we have to keep in mind that these are choices that are being made, and that we can, if we build enough political will, actually restructure the economy so that it works for the majority. How we get there from here is a lot of hard work, right? And that's where I think a lot of people are feeling depressed and sad. And I would try to urge people to turn that into sort of righteous anger and energy to help us really move forward. But I do think there's a lot of examples, particularly in healthcare around the world, where systems are set up completely differently, and where the quality of care is better for less cost, and where there's not this kind of financialization broadly of healthcare. So I do really believe that we need to shift our paradigms right now, and also keep working towards building the political will to build a better system.
Thank you so much for that, Lenore. Very inspiring. And I want to invite also Victor and Dawn, as we get close to the hour, to say anything else you want to share with the folks who have attended this webinar. Key takeaways you want folks to not forget.
If I can start, we've created a monstrously complex healthcare delivery system and an even more complex financial system, and it's not easily understood by the general public. They've got other things on their mind. It's not easily understood by experts. And I think a really important step here that you're taking with AFR and this webinar and others is to bring this issue to the kitchen table, to understand what is really bugging people right now. We kind of know in part because Gallup has done some terrific research recently, which shows three major concerns. One is out-of-pocket costs. People just know that somewhere in their paychecks or what's happening at the pharmacy counter or bills they're getting is the costs just go up and they have no control over it. Even middle-class people are finding themselves in medical debt. So that's number one at the kitchen table right now. It's not global healthcare costs. They could care less if American healthcare costs are 17% of the GDP, while it's in the Netherlands, it's 12. That's not speaking their language, but there is a language to speak. The second is access. People can't find doctors, clinicians, either primary care or when they get referred. And that is a downstream consequence of some of the dynamics that Victor and Lenore and Natalia, you have been talking about. And people need to make that connection to understand how we can get back to a supply of clinical care that really meets my needs when I need it. And the third is complexity, opacity. I don't understand this piece of paper. I don't understand my bill. I don't know how to make these decisions. People are not dumb. They're really smart, but we've created a monstrous system. And somehow we've got to speak the language of what's happening at home, and missed that boat so far.
Thank you for that, Dawn. Victor?
Yeah, no, those are great thoughts. And really appreciate Lenore's also, call for keeping energy and hope, even in really turning this the despair that we feel, and the righteous anger into action. And that can happen in a lot of different ways. I think that it is important what Don was saying about really connecting this to the kitchen table, to the clinic, to our communities. And I think Lenore also described some examples earlier of where this is happening. I think that healthcare is a place where actually some of those more popular demands can be made, and that more bottom-up energy actually is there. We saw what happened after, obviously a terrible event in early December with someone murdered, but the United Healthcare CEO, but we saw the public sentiment, the public outrage that came in the wake of that. So there is a lot of energy, but I think we have to find ways of actually channeling it in righteous ways, in productive ways. And I think that's part of these conversations. And I know there's a lot of people on the webinar thinking about how to do this. And I hope this we can continue to figure out ways to connect, and find those kinds of actions to take together.
Thank you all so much for this fantastic conversation. Apologies that we did not get to all the questions, but there was lively participation. So we'll have to follow up with folks, and just want to end by again thanking the panelists and thanking all the folks who took times out of their busy days to join us. And we have some links here. So you can keep appraised of news, alerts, and actions related to these issues. And you have here a link to Take on Wall Street, a campaign of Americans for financial reform, and also Health and Political Economy Project, HPEP, the program that Victor leads, and Lenore's website. So all of these are great resources, and we will be following up shortly with more resources into your inbox. And we definitely want to keep the conversation going. So thank you so much for joining, and we'll be in touch.
Thank you.